Alaikum warahmatullahi wabarakatuh. I would like to welcome all of you for this scoliosis webinar. We have 6 physicians from across the country will share with us today their cases. Our webinar today is focused on scoliosis and deformity. We will start with Dr. Ali Alsayegh, who is anesthesia and pain consultant at King Fahd Medical City Hospital in Riyadh. Please, Dr. Ali, can you start?
Bismillah ar-Rahman ar-Rahim. Thank you, Ahmed, and thank you for giving me this opportunity to present today about a very complicated case of kyphoscoliosis. And the beauty of it is it involved multidisciplinary management. As you know, I'm an anesthesiologist specialized in pain management. So I'm going to talk from my perspective, but it's going to touch on all specialities. Okay, so this is KFMC for those who don't know it. So our patient today is a 35-year-old male Saudi from Al-Hassa. He's known to have Scheuermann's disease with progressive kyphoscoliosis. Now, just to recap, Scheuermann's disease is a congenital deformity of the spine, in which the posterior, I'll show you a picture. If you see here, this is a normal vertebrae, and this is the wedge-shaped Scheuermann's disease, where the posterior end of the spine outgrow the anterior end. So this patient has got progressive kyphoscoliosis. He presented in 2013 to his local hospital with mid-back pain in the thoracic region following a road traffic accident, which resulted in a stable fracture of his T10 spine. His pain was moderate to severe but localized. He also has got scoliosis with a thoracic Cobb's angle of 9 and a lumbar Cobb's angle of 13. So he saw his local ortho physician in Al-Hassa who advised conservative management and he labeled him as a non-surgical candidate, and he was managed initially with oral analgesics, thoracic epidurals, soft tissue injections, and there was unfortunately no relief of symptoms. So in March 2015, he decided to go to London, England, where he saw a spine surgeon who advised him to have a corrective spine surgery, extensive. So he did a T2 to L3 corrective surgery with application of pedicular screws and application of transverse process hooks at T2 with rigid royals and osteotomy. This is the picture of post-operative. As you can see, pretty extensive surgery. Now, and this is the lumbar end. Also, he's got the screws. Now, unfortunately, in the postoperative period, the pain continued and was really severe, and he was unable to walk, and he also had weakness of his left ankle. So he referred to physiotherapy, rehabilitation, and pain management when he was in London, and they gave him a really good medications, lots of medications, as you can see, non-steroidals, muscle relaxants, antidepressants, and pregabalin, and all this was not helping. So when he came back from England, he was following up at Johns Hopkins Medical Center in Aramco, where one of my colleagues, pain physicians, saw him and started him on opioids. which was fentanyl patches and tramadol, but the pain was not controlled. So in January 2017, he decided to go to Germany, to Frankfurt, and he was assessed by a spine surgeon. So he advised him to remove all the plants that was put in by the fellow surgeon in London. And he recommended to have physiotherapy, narcotics, and rehab. Now, the patient still complained of severe mid-back pain, which is really strange, and weakness of the left ankle, limitation of his daily activities, sleep disturbance. He had depression and suicidal thoughts because of the pain. In July 2017, he was admitted to Prince Sultan Humanitarian City in Riyadh for rehab, had extensive multidisciplinary rehabilitation program, improved his function, but the pain did not resolve. So in July 2018, he was reassessed at Johns Hopkins Aramco, and they advised to undergo a trial of a spinal cord stimulator for him. Unfortunately, the trial was unsuccessful. It wasn't touching the mid-back. It touched the lower back where he had just mild pain and some leg pain. So they removed the implant, and they decided to put an intrathecal morphine pump for him, which gave him excellent pain relief, but unfortunately he had complications where he had severe urinary retention and difficulty urination. So the pain physician decided to remove it. So now he's left with no options, and the pain continued. So he was readmitted to Prince Sultan, where they just did rehab for him, and they give him pretty heavy narcotics, oxycodone, fentanyl patches, and drugs for depression and sleep. Now, I got involved with him in early March 2019, where he approached me for a second opinion. So at this time, my options were limited with this patient. There is nothing to do. This is a patient with severe pain, and he's an opioid dependent. So my initial plan was to get him rid of his opioid dependence. So I started him on methadone and advised to start him sessions of ketamine infusions. As you know, ketamine is an excellent drug for opioid dependence, neuropathic pain, and also for depression. So I gave him 2 cycles. He comes for a week, takes a cycle from Sunday to Thursday with increasing doses of ketamine IV under monitoring in the post-anesthesia care unit. It improved his depression, but it helped his pain for 2 to 3 weeks, but the pain referred back. So, and he keeps coming to me with this pain, and he says, please do something. So the only option that I had at that time was to do a peripheral field stimulation for him with a spinal cord stimulator, and I'll show you the surgery now. The patient had the procedure, gave him good pain relief for 4 to 6 weeks, but then he started to lose the stimulation, and the area of pain relief started to get lower and lower. And now he follows up with me for only to get his medication. So this is what we did. This is the area of the pain. He had 2 small incisions here, and we introduced the spinal cord stimulator subcutaneously, and I got it tunneled and fixed, and then anchored, and then we put the IPG here. So it was really an extensive surgery that took about 4 to 5 hours. So his current active problems are persistent mid-back pain, previous extensive spinal fusion, opioid dependence, depression, and suicidal thoughts. So just to summarize, this is a 35-year-old Saudi male, pretty young, known to have mild kyphoscoliosis, had a road traffic accident, and an extensive thoracolumbar spinal fixation with pedicular screws and persistent pain disability. He had the implant removed in Germany in 2017, had rehabilitation, nothing controlled his pain, became an opioid dependent with severe depression, failed spinal cord stimulator trial and failed intrathecal pump implant because of the difficulty in urination. So when I saw him in KFMC, as I said, opioid dependence management, get him an infusion, peripheral field stimulation, and we're still reaching nowhere with this patient. Thank you.
Thank you, Dr. Ali. Very interesting case. We have 3 minutes for questions. Since we don't have any question from the audience, I would like to ask the surgeon on the panels to comment on this case. We'll start with Dr. Anouar, then we'll move to Dr. Bassi. So Dr. Anouar, what do you think, in your opinion, happened with this case?
Yeah, it's very interesting and very intriguing case, actually, because we don't understand completely why he had all this kind of pain. But we can notice that the first surgery, we don't understand really the indication and the construct that was done, bypassing all that area of the fracture, like a kind of, like if it was a kind of growing rod, we don't understand. So it's a very difficult case, honestly. I don't know why he had all these pains. And we can see that despite what was done, he still has the pain. So very, very difficult case, I think.
The patient, Dr. Ali, had a CT scan at any point to see if he had non-union or?
Well, he had a CT scan done outside. I didn't put it in here. No, there was no non-union. Actually, it was healing fine. It's really puzzling why he's got this pain. At some stage, I thought that this patient was malingering, actually, but no. When I even interviewed his family, and the family said that, you know, he really cries with this pain, which is really puzzling. And there is no reason why all this pain, and he's on these heavy doses of narcotics, and he had all these procedures done for him.
There's 2 questions from the audience. One of them, they're saying that he's asking if vertebroplasty can help in this patient. What do you think, Dr. Bassi? Dr. Bassi? Anyone?
Yeah, thank you. Actually, this is a challenging case, especially the pain. I think we call it the hidden disease, that you can't see the pathology, you know. Vertebroplasty can help, but not in all cases. And when I consent my patient to do vertebral or kyphoplasty, usually I consent them that they might not improve. Actually, so far we don't know before the surgery if the kyphoplasty is really effective or not until we do the surgery. So I think the option Dr. Ali he proposed here and he did for the patient, I think it's one of the solutions. Vertebroplasty is another solution, yes, but unfortunately with the spine, it's a trial and error. So we don't have really a test that can show us that which one is more effective. We have patients, we did surgery for them, fixation. They came with the pain even at the upper level, above the level of the fusion. When you review the CT scan, as Ahmed he mentioned about the CT scan, we do nerve conduction. There is nothing really significant. We look at their socioeconomic. We use antidepressant, morphines. It doesn't work. So the only my points here, and I think the system, it's demanding. It takes 4 to 5 hours. I think Dr. Ali just mentioned. It takes long time to apply. Although as well, it is expensive set. So not every patient can provide it, especially when we talk about the private sector as well. The insurance and even the patient, they can't afford it. I think it ranges from, as I remember, from 15 to 20, 24, 25,000 the set. So yes, it's. I think vertebroplasty is another option.
Dr. Ali, you mentioned he's a sickler. He's a sickle cell disease
No,
patient.
he's not a sickler. No, he's not a sickler.
Okay.
No, he's got G6PD. He's got G6PD, but that's not not relevant to his problem.
Okay, because we're running out of time. Any of the panelists wants to comment on this case?
Actually, just the last point. I think the only thing that I'm thinking of doing to him is to repeat the intrathecal pump, but not with morphine. I'll try to use other drugs, probably use some local anesthetics with clonidine, and try, maybe, this will relieve his pain, but I really doubt it because he's gone over this. Now, he comes every few months to take the ketamine infusion, but because it helps his depression, actually.
Okay, but he did not get any epidural injection, yes?
He had before. Abdullah Al-Ghamdi in Aramco gave him a few injections. It helped him before the surgery. After the surgery, he had it once. It didn't help him.
Okay. And no infection, of course. Infection was ruled out in his situation.
No.
Okay. Okay, thank you, Dr. Ali. We'll move for the next case. We'll move to Dr. Samir Alsayegh. He is a pediatric and spine, orthopedic and pediatric spine consultant at the National Guard Hospital in Riyadh. He will present a nice case for us.
Assalamu alaikum wa rahmatullahi wa barakatuh. We will talk about a complex congenital scoliosis. It has the patient is a 16-month-old girl, product of full-term normal spontaneous vaginal delivery with no antenatal or postnatal complications, and presented with a complaint of progressive back deformity noticed by the family. Normal developmental milestone was noticed with the child. Clinically, the patient is having a left thoracic curve with a trunk shift to the left, normal muscle power examination. Sensory assessment was very difficult as the child is small. Normal symmetrical reflexes and no signs of hyperreflexia in the lower extremity or the upper extremity. Radiographs shows congenital scoliosis with a complex type, mixed type. There's a hemivertebrals and bar formation. Also, the rib in the right side of the thoracic was fused. From these findings, it's a high chance of progression, and we started immediately of a further investigation of an MRI, the whole spine, CT scan of the spine and the thoracic cage, echocardiograms, and ultrasound of the abdomen to rule out cardiac and renal congenital anomalies associated. MRI was done under general anesthesia, and it shows diastematomyelia of the cord from T6 to L2, with the bony septum at the level of T9 to T11. And also the conus medullaris was low-lying at the level of L4, L5. And you can see the image, the bony septum and the two canal or the dura sac with the cord in it. And other images of the MRI, it shows the bony septums, and also here in the other images. CT scan, it shows the bony septum here in the 3D reconstruction and the coronal section. Echo was normal, and ultrasound, it shows only right kidney hydronephrosis grade 1. And after all the investigation was done, another radiograph, it shows a progression of the deformity. Even the lung volume in the right side start to be smaller than the left side. And patient during that period has a recurrent admission due to chest infection and complication from bronchial asthma. So if we go back to the patient is having a documented progressive scoliosis, the congenital type. diastematomyelia of the cord, tethered cord, and rib fusion causing a smaller size right lung. So the operative plan was to do the surgery in 2 stages. The first stage by the neurosurgery, where they go for resection of the bony septum and repair of the dural sac and untethering of the cord at the level of L5S1. And you can see that 2 dura and where the septum was there and was resected by the surgeon. After 1 week, the second stage was planned for the implants of the spine. We addressed the issue of the rib cage by doing rib osteotomy and insertion of a vector rib to rib to expand the right hemithorax, and interposition of muscle between the ribs was osteomatized. And this osteotomy was continued all the way to the bar at the spine. Then we inserted the spinal-based growing rods to control the trunk shift and the scoliosis. The other solution was to put a vector rib to spine based construct, but it was too bulky for this child. And we decided to go spinal growing rod, a conventional type. This is the follow-up after 6 months post-operatively, as everything is maintained and stable. And this is after the first expansion of the growing rods and the vector. And the patient is still continuing in follow-up in my clinic, and the patient is still planned for the second expansion soon. Thank you very much.
Thank you, Dr. Samir. Very interesting and challenging case. Since I have only one inquiry from the audience, is the patient has a thoracic spinal bifida, and he can see that from the 3D CT scan.
Yeah,
it's a comment.
Mm-hmm.
The question that it came to my mind, but you already answered that, why you did not do rib to vertebra construct, because that will reduce the amount of metals that you could put in this patient. You chose to use the vector to extract the ribs, and you choose to use growing rod construct for the spine. So why you did not use the rib to vertebra construct?
So when you use the vector for rib to spine, the screw size will be 6.35 in the lumbar spine, and they are bulky construct. We use the spinal growing rods 4.5 system. The patient is just 2 years old, and it was gonna be very bulky construct for.
Okay, and of course you did use multimodality neuro monitoring in this case. So any changes, anything happened?
No changes during the surgery, both stages. Alhamdulillah.
MashaAllah, MashaAllah. And so far, alhamdulillah, no wound complication or hardware prominence or
no. Okay. So far, follow-up not without no complication, alhamdulillah. So far.
And you did not consider to do preoperative halo gravity traction?
With the bars and the bar formation, the scoliosis is deformity is too rigid. So what we have done is untether and release the spinal cord, give her a rest for a week. Then we brought her for the osteotomies to do acute correction instead of gradual correction, because it's a rigid congenital scoliosis. It will not help.
There's a question by someone said, at which age do you operate in case of congenital scoliosis?
Which, sorry?
At what age you would consider to operate on congenital scoliosis?
All it depends on the progression of the deformity. If the deformity progressing, and like in this situation where there is a hemivertebra and contralateral bar, this is a high chance of progression, and with other congenital anomalies of the spinal cord, this is push us for early surgery. But other cases, we will follow the patients. If there is a progression of the deformity, we'll go for and our cup angle measurement may be around 40 to 50 degrees for our surgical intervention.
Usually I try to push them up to the age of 3 or 4, but sometimes you have to operate sooner, like this case. But most of the time, I'd like to delay them at the age of 4 years. Any comment, Dr. Anwar, about that? What age you usually open, or Dr. Bachar, since you guys do lots of congenital scoliosis, at what age, there is a certain age that you prefer to operate on?
I completely agree with Samir. As soon as we can put some screws, so after the age of 18 months or 2 years, if the angulation is really above 35 or 40, and it has big chances of increasing, I would go for surgery. But of course, it's a very, very challenging and complex case.
I always say for the congenital scoliosis, there is no guide, clear guidelines, or like the AIS, we have linking classification, and we go by, like we can easily plan our surgery. In congenital scoliosis, I always say each case is unique, and each case has its own plan. And sometimes you have to be very creative and think out of the box. Dr. Bachar, any thoughts about this case?
This is a very nice case and well done. Usually, whenever I plan to put like destructive instruments like growing rods or so, I would like to have the patient more than 5 years old if possible, to avoid this growing problem with the growing rods, if possible. Yeah.
Dr. Samir, there's a question says that we did not see a full spinal correction even after 6 months. Is there another operation schedule when the patient grows up?
Well, the growing rod system is mainly to stop progression of the deformity. Yes, in the first stage, well, our aim is to get correction as much as possible, but the main reason of the growing rods insertion is the control of the progression of the deformity, your first aim, stopping the progression of the deformity. So I'm not expecting to get any further correction of the spine. As long as I will keep it the same, I win the battle of this difficult, complex case.
I completely agree, Dr. Samir. One last question: why you did not use, why you didn't consider a magnetic rod for this patient?
The patient, the vector is gonna have an expansion every 6 months. So putting a magic rod, it doesn't make sense, as the patient will come under general anesthesia for the vector expansion. So that's why I put a conventional growing rod of the spine, as the patient is coming for an expansion anyway for the vector.
Okay. So thank you, Dr. Samir. It was a very interesting case. We'll move for our next speaker, Dr. Anwar. Dr. Anwar, he's a spine consultant at Al-Kingdom Hospital, Al-Mamlaka Hospital in Riyadh. He will present to us a very nice case as well.
Thank you, Ahmed. Assalamu alaikum. So you see my full screen?
Yes.
Okay. So it's another congenital case, but I think it's more straightforward than the one of Samir. It's much simpler. I wanted to share it with you just to show you the evolution, the natural evolution challenge, and interesting features of some regular, let's say, congenital cases. Sorry. So it's a 4-year-old boy with a Treacher-Collins syndrome. He had a normal birth with a normal walking, but some dysmorphic features were early noticed. He was operated for a cleft lip and palate at the age of 9 months. Also for the testis at the age of 2 years. In addition to all of that, he had blood disease, what is called thalassemia media. So he has frequent transfusions every 2 months because he has very, very low hemoglobin levels that may drop down to 6. In addition also to that, scoliosis was discovered at the age of 2. I saw actually the reports. I couldn't have the pictures, but the previous cob was around 35 degrees and was treated with a brace. And he had a normal neurological exam. So this is his X-ray. So as you can see, he has a double major scoliosis. We can notice here that also he has coxa valga bilaterally. So it's a double major scoliosis with angulations between 40 and 50 degrees between thoracic and lumbar. He has a pelvic incidence of 60 degrees. I think this is important to see for the sagittal balance because it means that he is supposed to have a little bit big curves at the area of the lumbar and thoracic spine. The measured thoracic spine, thoracic kyphosis here is 65. So I think compared to his pelvic incidence, it's important. It shouldn't be above 55. So, double major scoliosis at an early age. When we see his CT scan, we can notice some congenital anomalies, and mainly this non-segmented T9 hemivertebra on the right side that is actually causing the main thoracic curve and the compensatory lumbar curve below. We can notice that below the hemivertebra we have a spina bifida at the level of T10 and also at the sacral area. This is the CT scan. You see here the completely non-segmented T9 hemivertebra on the coronal view and on the sagittal view. MRI did not show any cord anomalies.
Dr. Anouar, can you press to get onto presentation mode, please?
Sorry?
Can you put it on presentation mode so the picture will be bigger?
Oh, sorry. Yeah.
Thank you.
Better?
Yes, thank you.
Yeah. So this is the CT scan and the MRI. And so regarding the actual situation, what would be the management options? It's either to continue the conservative management until an older age, or to go with the hemivertebral resection and do a short construct. Eventually, we can combine hemivertebral resection with a kind of growing system, or to go only with a growing system. So my decision actually was to go for surgical management because of the evolution of the scoliosis between the age of 2 and 4, and because it's a non-segmented hemivertebra that is going to evolve. And as we mentioned before with Dr. Samir, we can operate at an early age. So I went with the second option of hemivertebral resection and doing a short construct. So I will just share with you the intraoperative images. I did 2 levels above and 2 levels below fixation because sometimes when we do the hemivertebral resection and we do just 1 level above and below, if the gap is important, we may have a failure of the screw, especially when there is a kyphosis. If there is a kyphosis, the load is going to be important. So it's better to reinforce the screw with another level. Here you can see the spatula underneath the 9th rib because we will need to resect the hemivertebra. So it's like a vertebral column resection on one side. So we need to remove part of the rib like 2 or 3 centimeters. This picture actually is just to show you the size of my thumb and fingers compared to the field. So it's a very small field. So you need to be really very gentle and smooth while you are doing this kind of surgery. This is after the hemivertebral resection. Here is the exit route that goes below T9. And here also you can see the size of the field because compression devices are almost the size of the field. And so in this case, to avoid having overload on the screws, I did the compression on one side with two compression devices, so above and below here, and also above and below with a bigger compression device. Sometimes we can use a domino or a connector, but of course at this age it's very, very small. So this is the final reduction here, when you can see that the screws above and below are really close to each other. We could close the gap, and at the end I cover usually the defect with a gel foam before putting the graft on the whole area. And so this is the immediate post-op X-ray. Of course, I did a cast for this kid to be worn for about 3 months, especially to protect from the compensatory curve, because we know that the compensatory curve may be dangerous sometimes. So I was really happy with this finding. And as you can see, the angulations decreased to 18 degrees and 23 degrees. And even the kyphosis decreased to 50 degrees. So I saw the patient after 3 months. Sorry, this is the post-op CT scan. Yeah, I forgot to say that I put some bone graft from the back inside the defect from the hemivertebra to increase the chances of bone healing. Okay, I put the graft from the right side, as you can see it here on the CT scan with a bridge here. So I saw him again at 3 months, and so at 3 months, you see how there is again an increase in the curves. So when I measured them, they increased to 26 to 28 degrees between the thoracic and lumbar. It's not, of course, the pre-op measures, but still they increased. And regarding the sagittal balance, it's very similar to what it was before. So I wanted to show you this finding because it shows the how it's unpredictable, the evolution in congenital scoliosis cases, and it's not always as satisfying as adolescent idiopathic scoliosis, unfortunately. So this is the X-ray at 18 months. So after 1.5 years, you see it's globally stable compared to the 3 months, with angulations that are around 29 or 30 degrees, to be honest. Sagittal balance is still the same. Patient is not complaining. He's living a normal life. But you see, we had like maybe 50 or 45% of correction. So this is the comparison between the pre-op and the last follow-up. You can notice eventually that the coronal alignment eventually improved because the C7-PLOB9 is more centered on the last follow-up X-ray. And I wanted to share with you this paper from Madrid that was published last year in the Spine Deformity Journal, where they say regarding the hemivertebral resection below the age of 5 years that you may have a good initial correction, but usually it's around 50% at the final follow-up. So don't expect to have very big correction that will be maintained at the long run in congenital cases. The compensatory curve also partially corrected, and even it was at 25% at the final follow-up. And coronal balance worsened at the final follow-up compared to the preoperative coronal balance. Thank you for your attention.
Thank you, Dr. Anouar. Very interesting case. I do have a similar case that initial X-ray after surgery was excellent. Then I'm following her, and I see a little bit of curve progression. And I totally, you mentioned one point, which is very good point, that I usually always prefer to cast those patients after surgery. So kids, once their pain is disappeared, they will jump all around, and they may dislodge the construct. So casting them at this part, at this stage is very important. Dr.
True.
Samir, can you comment on this case? Do you have any questions?
We can see that it was documented progression. This is the point. And after the surgery, there was a correction of the deformity. Yes, there was a little bit slightly loss of the correction in the beginning, but it's been maintained. This is our aim of the surgery, is to prevent the progression of the deformity in congenital scoliosis. This is our aim always, not fully corrected. But I was gonna ask about in the lateral view, the rods are a little bit straight. Why we didn't maintain it a little bit in kyphosis, Dr. Anouar?
Regarding the sagittal?
Sagittal. The rods are a little bit straight rods, not bended in the kyphosis in that area.
Yeah, because actually I was eager in the surgery to correct the initial kyphosis. So I wanted to try to correct it because I felt it was important. But unfortunately, even with the correction, initial correction, he created kyphosis all around the operated area because it seems that his balance requires that.
Yeah, he's happy with that, his previous kyphosis.
Exactly.
Yeah.
Exactly. He will remain like this.
Yeah.
Good job. There's a question about why you did not use a growing rod construct. It's a very good question.
Because I felt that I may have a good chance of reaching a correction because you saw how it's a complicated kid. He had many surgeries. He has transfusions every 2 weeks. So he's always in the hospital. I felt that I may reach an acceptable result by doing a short fusion a single time. And eventually, if something goes wrong later on, to put a growing system. Because otherwise he will go to have a lot of surgeries in the next 5 years.
Yeah, I think, and even if you look at sometime with the congenital scoliosis, usually the curve is small and sharp. It's not like a big curve like the one we see usually in AIS. If you think that you can just correct most of the time, if you take the hemivertebra, that curve get corrected, so you don't need for the long fusion or long construct.
Yeah.
Okay. Someone was asking about the rule of anterior release in both cases.
I honestly almost stopped anterior release because we can do a lot of things from the back unless it's really extremely complicated.
Okay. There's so many questions. I'm trying to find the most interesting one. Of course, you answered that about if you will not consider a magic rod for this case because it doesn't need the long fusion or a growing rod construct.
Yes. Yeah. The aim was to do like the classical hemivertebral resection, but at a very young age, and to do as short construct as possible.
I have a question. What technique that you use for the resection? How do you resect that hemivertebra? There's so many techniques. So which one do you use?
It's like if I'm doing a pedicle subtraction osteotomy on one side. I remove the rib, I open the foramen above and below. After that, I remove the posterior arch, and I, with the very small osteotome, I start to remove in a wedge fashion the vertebral body, and after that, the disc above and below, and the posterior wall by pushing it anteriorly.
Yeah.
And I try, as I have showed on the CT, to put the graft inside and to close it on the graft.
Of course, there's other technique, which is the eggshell technique. Usually I go with it because I think it's, for me, I think it's much easier. And the eggshell technique, as everybody knows, that it's as you're putting a pedicle screw in the pedicle of in that hemivertebra, then you just squeeze or take all the bone, cancellous bone out, then until the edges stays, and after that, if you do a compression, that hemivertebra will collapse, because the idea of eggshell technique is to make that hemivertebra weak so you can compress. That's another way to do it.
Yeah, true.
Okay, so we'll move for the next case, Dr. Bachar. He's a spine consultant at King Fahd Medical City in Dammam. He will present to us a nice AIS case. Dr. Bachar. Thank you, Dr. Anouar.
Hello? Hello? Hello?
سامعينك دكتور بشار.
بسم الله الرحمن الرحيم. First of all, I would like to thank Dr. Ahmed for the invitation, and it's an honor to me to. It's an honor to me today to be with you guys. Do you hear me?
Yes, but can you move your? Can you share your screen?
Yeah, it's not sharing. Sorry. I'm pressing sharing, it's not sharing. Do you see now?
Yes. Can you? Yes.
It's better now?
Yes.
Okay. So my case today is a very simple case, but hopefully it's at the end we'll learn something from it. So this is like 15-year-old girl with the typical AIS case. This is an everyday case. You will see this kind of cases every day in the clinics. So with the thoracic curve of 74 degrees and proximal curve 40 degrees and lumbar curve of 45 degrees. With the modifier type B. So on the bending views, it looks to be not quite flexible. It's like a triple major curve. So usually for this kind of cases, the difficulty is where to stop down. What's your lowest instrumented vertebra? So whether you stop, you do selective fusion or you fuse the lumbar spine. So I don't know, Dr. Ahmed, where do you stop? Do you do selective on these cases or you fuse the lumbar spine?
I'll go with the last touch vertebra with the central vertical sacral line. So I will here in this one, I will stop at L5432.
L2 or L1? Yeah, this is L1 here.
Yeah.
This is L1.
I never stop at junctional, even if I'm doing, even if I'm going to do a selective thoracic. I don't like to stop at junctional like T12.
Mm-hmm.
But at this case, I think I will stop at. Wow, it's. Can I see the bending again? I think 2 is reasonable, but although 3, it can be because there is lots of rotation in 3. Let's ask Dr. Bassi, Dr. Samir, and the rest.
2, 3, 1, 2, 3.
Yeah, Dr. Bassi, Dr. Samir, what do you think? Where you will stop?
Can we see the lateral bending views?
I'll stop at 3. There is a good rotation in 3.
Yeah, I think I agree with you. I think 3 will be enough. So I think it's better to preserve the. But is the 3 above the curve, the apex of the lumbar side?
Sorry.
Can you go back with the previous? Yes. Okay. Yeah, it's. I think I would go with 3. 3. I think it's very good. There's one of the theories also, Duby, he mentioned that any disc that mobilize, even if there is about 5 to 30 degrees, the average with the lateral bending views, usually he doesn't involve them in the fusion. So I think it will cause some shifting of the mid-sacral line to the left side, sorry, to the right side. I would go with 3. 3 is more stable here.
What do you think, Dr. Samir?
The lumbar curve, is it flexible? It's Linky 4, it means it's rigid, right?
Yeah, it's 30 degrees.
30 degrees in the bending. So you have to include the lumbar curve. So L3 is a good option, I think. It's attached vertebra. Stopping at L2 is not a good option because the apex is the disc between L2 and L3. So you have to go below L3 or L4.
Dr. Salah?
Yeah, I will go for L3 also.
Okay.
Oh, perfect. So as you said, guys, it's a little bit debatable where to stop. So whether L1 or L3, L4. I plan to stop at L1, in fact. So, and this is the immediate post-op X-ray. You could see that, yeah, immediately it's like the patient is a little bit off balance and shifted to the left side. So I told the family that it's expected immediately to have something like this. Hopefully it's gonna improve in 6 months, as usually 6 months. So I repeated the X-ray after 3 months. It's getting worse. You see, there's like wedging at L2, L3 area here. There's like curve, about 30 degrees curve here. And still we have this shift. So at this stage, anybody will do anything or wait? Or what do you do? What do you do, guys, at this stage?
I will wait. 6 months. 6 months.
3 months.
3 months. I'll wait. Definitely, I will wait.
Okay, we repeated the X-ray after 6 months. It's still the same, or maybe even worse. You see, it's the patient is off balance and shifted to the left. So the kid is not really happy with her shape. She feels that she was even more balanced before the surgery. So what do you do at this stage?
Because this is the issue, because you partially fused the lumbar curve. So either you was gonna stop at T12, ignore the lumbar curve completely, and undercorrect the thoracic curve. So it will be compensating each other, the remaining of the curves, or you have to include passing the apex of the lumbar curve, which is L3. You have to go to instrument until L3.
So what do you do at this time?
You have to extend the fusion, unfortunately, to L3 now, a second stage.
What do you do, Dr. Ahmed and Dr. Mahdi?
Well, I will wait as much as I can and look at the patient's symptoms. But if the balance is getting worse, definitely I will extend my fusion.
Actually, it depends also about the patient, about the hyperlaxity. If the patient hyperlaxity from the beginning, some of the recommendation that we have to go.
Yeah, she's not Marfanoid-like syndrome.
Yeah, Marfanoid-like, and that's one of the issues. But I would go with Ahmed. Usually I wait up to 1 year and send her for physiotherapy, exercises, increase the core strengthening muscles. This I had one patient similar to this situation after physical therapy, but it's a course, a big course. She improved actually. Chiropractor plus minus it can help. But I always, whenever I go with selective procedure in this situation, I always explain to the family that I might go back again and fuse down to L4 or L5.
Sure.
What do you think?
Well, I think I will wait. I have a case like this. Usually after 1 year, I think there is some maybe not like improvement much radiologically, but clinically or the satisfaction of the patient. So I will just try to push the time. But if I need it, so I will go, like Dr. Samir, he said, I will go and revise the case to L3 or L4.
Yeah. So I put her in a brace, in fact, trying to buy some time. But, you know, I waited another 6 months, and this is the X-ray at 9 months without any improvement.
It's unchanged. It's
Yeah,
unchanged.
yeah, little bit. She's a little bit balanced, but she's still very shifted to the left side, as you can see here. So I discussed with the family if we can wait another 1 year and see what's gonna happen. They agreed. So I waited. This is at 18 months here. She's better. She's better, and the shift is a little bit better. At 2 years, she's much better. You could see that there's a shift and coronal off balance is much better. So, and even the curve of the lumbar curve has decreased from 30 degrees to 14 degrees here. And you could see at 3 years, she's even better. She's getting better. You'll see now she's perfectly balanced, and the shift is much better. So as you can see, this is an pre, and this is after 3 years. The patient is very happy now. So hopefully we're able to save her lumbar spine. So here the lesson that you have to wait like 3 years to get the final result here. So I was at 6 months. I was not expecting that she will improve because she's getting worse, but with time she improved. So the question here now, so is there any way to do like multi-center study for this modifier B and C and study our cases and present them at, for example, at the SRS or whatever you see, guys? So if we could collect cases from all Saudi Arabia, from Jeddah, from Riyadh, from everywhere, and do like multi-center study, selective versus non-selective, and see if we get like 200, 300 cases and study them with the like 3 to 5 years follow-up.
I think as we were talking that all of us has such cases, and it's a great idea for a multi-center study. And I always tell the resident that those young patients, they always surprise you. So always, if the parent understand and patient is doing fine, always go with conservative and wait until to the point that you have to go for surgery, because such things can happen in a pediatric age group. One of the question was asked that if there is any waist asymmetry during all clinically.
Yeah, the waist symmetry. This is like on the X-ray, it's like the triangle shift. It's improving over time, as you can see here. They say waist asymmetry is much better here. By the way, I consulted Larry Linke on this case. He thinks that I should go back and operate on her at 9 months. This is just to see that this is a difficult topic, and nobody can give you the correct answer. That's why I'm asking for multi-center study to have something like study on that.
Someone when you asked us where we will stop, and most of us said L3. So why did you stop at L1? Did I miss that?
Why I stopped at L1? Because L1 is the if you want to do selective, either you stop at L1 or at L1 or D12, like yes. Here. So that's why I stopped. Yeah, you can see that here the stable vertebra is L1. That's why I picked L1.
But we know that from the discussion that the lumbar curve was a rigid curve, and the bending film, the lumbar curve went down to 30. So that means it's a rigid curve, and even the X-ray shows lots of rotation. So why you still wanted to go with a selective fusion in this case?
I got your question. So remember that in 1993, Larry Linke and Keith Bradwell, they published about selective fusion criteria. If you have curve over curve more than 1.2, rotation over rotation more than 1.2, and translation over translation 1.2, you could do selective, even if this is like rigid. You know, this is the idea of selective. And even I had the case where it's lumbar C and it's rigid, and even I stopped at L1 and it worked. So, but this was more difficult than the modifier C. I was expecting that to be much more difficult. So for this is the idea of selective fusion. So it's not whether structure or non-structure. Ideally, you have to fuse all the structural curve. But in fact, if you could save the lumbar curve, it will be much better. Like in this case, even if it's structural, but with time it will correct, because the thoracic curve is much bigger than the lumbar curve. This is the trick here in this case. Okay. So hopefully, if you correct the thoracic curve, you could save the lumbar curve.
Okay. Thank you, Dr. Bachar. It was a very interesting case. Because of time, we have to move to the next speaker, Dr. Salahadden Khalifah, because we want to keep Dr. Bassi to the end because he has a very interesting case. And for the audience, I'm trying to answer most of your questions by typing, and some of the question that you're asking is being answered by the speaker as he's presenting. So excuse me if I couldn't answer all the questions, but I'm trying my best.
Bismillah ar-Rahman ar-Rahim. Is my voice clear for everyone?
Clear and loud. Wow.
Okay. Okay, so Bismillah ar-Rahman ar-Rahim. First of all, كل عام وانتم بخير للجميع ونسأل الله أن يرفع الوباء والبلاء. I will just go to this case. Interesting case. She's a 14-year-old female patient presented to my clinic with a picture of Marfan Syndrome. She's having back deformity, progressed very quickly over the last year. She was traveling with her family from one city to another till landed to my clinic. So she's having this picture. Without going in further detail, I would like to have some opinion from a lot of seniors in the group I can see. So there is a vote. So Mr. Bilal, if you may put the vote, please. For this case, if you have this case and you want to tackle this patient surgically or non-surgically, whatever, so can you go with those options? Number one is like non-operative treatment since it's almost rigid and won't progress. Traction for 6 weeks, then posterior. First stage anterior release, then second stage posterior release, then surgery all from posterior. So we'll just have like 30 seconds or 20 seconds to have some of the expert here.
I will add intraoperative traction, Dr. Salah. I would do that.
Yeah, okay. So this is what just not to complicate things for the people. So less options, let's say. So 10 seconds more, then we'll go for the presentation. Okay, Mr. Bilal. If we may see the results. Oh, interesting. So non-operative, you have like 6%, 24% with 6 weeks, 36% anterior than posterior. Interesting. And surgery from posterior is 35. So it's really challenging with that. Many.
What did they choose? The panel, Dr. Mahdi? Dr. Samir, Dr. Bachar, Dr. Anwar?
Yes. I would
Mahdi
go.
anterior, for sure.
Yes, actually, it's two schools. Yes, I would love to go anterior, then posterior. I would do aggressive release from the anterior, and I think it is really effective. I have a few cases similar. I go with selective thoracotomy there. I'm using actually the ACDF cages, the big cage for the cervical. I go here with the apex area, do release, and put the cage, reduce the curve, and plus minus traction, and then once the patient reach the suitable age, then we go with serious.
Dr. Samir, what do you do?
I will go for preoperative traction and assess the deformity correction. Then we'll decide either if it's too rigid, there is no correction with the preoperative traction, then we have to go for anterior. But if there is a correction and acceptable, then I will go with an intraoperative traction with posterior only correction.
Anwar?
Probably all posterior.
Okay, Dr. Bachar?
Yeah. For me, I don't do any traction for these cases, even a pre-op or intra-op. I do like 10 ponte osteotomy. Probably he will lose the signal, so he could stage it. So and then do it one time. Sometimes it works. Even I get cases like 150 degrees, and it works like this.
Interesting answers, Salah. I will go with the intraoperative traction and posterior only. Okay, go ahead, Salah.
Okay, so I think the varieties of the answers that reflect how much complicated sometimes the scoliosis and the panel discussion is really great. So I will come back to this picture, but just let me go. So those were the options. So let me just take you through the steps or the journey of this case, from preoperative, how to choose your instruments, anesthesia, position, facetectomy, pedicle screws, osteotomies, and so on. First of all, this case is Marfan syndrome. It's one type of the, let's say, syndromatic or muscular problem, connective tissue. So we have many options and many classifications for the scoliosis. There is a nice article about the only spine deformities in Marfan syndrome, and summarize many problems, and it's like clinical diagnosis more than sometimes genetics. So you'll send the patient for genetics or pediatric, but like very important is to have like a very good pre-operative plan and to diagnose the cases, because really those cases, if go wrong in the surgery, the patient will lose his life because of the cardiac issues, aortic dissection, and the bleeding, the mortality rate, and stuff like that. So first of all, you need to diagnose it as Marfan syndrome. What's the good maybe in those cases is the elasticity. So elasticity will help you in your reduction. Some preoperative planning is the MRI for sure for those cases to see any anomalies or spinal cord problems. And you can see here in this cut, the disc is not rigid, so there is some flexibility, or you'll hope some reduction because of the disc here. Otherwise, it was insignificant. So preoperative, like cervical, echo is very important, and the preoperative work plan, I will not go in details for that. So back in my old days in the fellowship, preoperative for the scoliosis cases, there is a lot of puzzles you need to connect, like the upper end vertebral, the lower end vertebral, structural curve, non-structural curve, the skin, the neurological manifestation, flexibility, sagittal profile. So you need to gather all of those information. This is will add more complexity for your decisions. So back to this case again. So this case is like around 105 degrees. If you do some bending, it will come back to 78. So there is some hope. It's like 15 degree or 20 degree, let's say. The lumbar curve was very promising. So in this case here, at least to L4, there is some rotations, but if you do some bending, it's going to come back. So I selected to stop between L4 or L5. So one of the manifestation for the Marfan syndrome, they have sometimes spondylolisthesis, sacralization, and stuff like that. So you need to study that very well. And I decided to go all from posterior without traction. So it was really like what Dr. Bachar said, I will go for Ponti, osteotomy and stuff like that. So I took the decision and we prepared the case. So this is like some pre-operative, and you can see here, although she's having like a massive hump there, but it is not like there is some flexibility with that, especially in this picture here. Maybe it is not like the ugly hump you can see it with the 110 or 120 in cerebral palsy or other cases. So some strategic planning for the patient. So for example, this Jackson table, if you see here, usually we are 90 degree, but because of the flexibility, I just push the hand up. I always expose the neck here, so to have like space for going up and then the scrubbing, and also neuromonitoring is always there. Some preoperative planning here and there. Here is very important step, and I think this helped me a lot in the facetectomy. So always I'm keeping asking my trainees and the residents why we are doing facetectomy. So facetectomy is, if I just gather some information, it will increase your flexibility, more coronal and sagittal correction, compression of the convex curve, less pull out of the screws, increase the surface area for fusion, and you have autograft, identify the pedicle screw landmarks also, although you have the navigations, enhance the fusion, and it's like step number 1 for Ponti if needed. So if you do like very good facetectomy, this will help you a lot. But the downgrade for that is the increase of the bleeding of this. The navigated high-speed drill, it's like a game changer for me. So I will show you some video here. If you have like very small pedicles, and you will go with this, it's really, if you can go with the navigations with the Midas Rex or with the speed drill, and then it will make your life very easy and very safe, and you will go there inside. And even in the very narrow slit pedicle, sometimes you can, maybe this one is not like the most narrowest in the surgery, but just to demonstrate that, you'll go with the Midas up to the vertebra. And always you have like a posterior here, like a closure or something. So if you go with the Midas or with the speed drill, it will help you a lot. And I did not used to do with this without navigation before. So it was always with the pedicle finder. So this is like a very strategic. If you have navigation, try utilize this important tools, especially in those cases. Then I went for Ponti, but it was not like 10 levels like Dr. Bachar recommended. It was like 3 or 4 levels, not too much. And always, this is in my belief in Ponti, it's not necessarily to remove everything. The ligamentum flavum is very important here. So if you remove the ligamentum flavum, even this part of the superior articular process, sometimes if you leave it, because it's super flexible here and you are already dislodged the vertebra. So, but I think the ligamentum flavum is very rigid here. So if you manage to remove the ligamentum flavum and the neuromonitoring, and luckily I did not have any signal lost in this step. So I think this is from another case, but it's something similar to this one. Then you'll start your reduction. So always with those cases, you need like 2 rods at the same time. I think this is one of the best things. This article is very, very nice. And this picture I printed for my trainees and residents in the OR. So it's in front of me. Whenever I'm starting to contour my rods, just I'm looking to this one, and we are contouring according to this one, as everyone knows. Hyperkyphotic in the concave side and hypo in the convex side, and so on. And this article, I recommend everyone who's dealing with scoliosis to go back. Faldini, he did it like 2018 or something. And what he's trying to push from the concave side and restoring the apical kyphotic. And this article, so triplanar correction. So he's playing with all the steps of the correction from vertebral derotation. So what I'm doing is like this, my workflow in the correction, and I recommend everyone just to go and relax in this step. Don't rush and correct it quickly, because you are spending a long time to put external pedicle screw. And now in this step and the decortication step, always some of the surgeons, they are in hurry. So I think we need to have our time. So contour the rods. If both rods, this is excellent. Then rod placement, rod derotation. but don't look, don't kiss the rod. He's saying kissing the rod. So no kissing of the rod. Just loosely, the proximal and distal end, just try to reduce it loosely. Then you start playing with the apical vertebral derotation and consequential reduction. Sometimes even I'm not doing full turn. I'm doing like half turn, sometimes quarter turn. So because if one screw pulled out, you will be in a bit longer the surgery, because you need to go back and put a bigger screw and don't lose your pedicle channel that you did there. Then before you tighten fully, do the compression distraction. So you will do 3-4 steps in the same time with your assistant. And after that, you will have good. In the AO Spine Member Plus, there is a lot of webinars, and Dr. Oled, he's describing this in one of the videos. So this is also, I recommend you, since we have time now, to go and review, especially the people who is interested in the deformities. Irrigation, this is maybe inspiration of Dr. Alturkistny. So always those cases, you need to do a lot of irrigation post-op or post-reduction. So sometimes I'm reaching like up to 10 liters. With irrigation, a lot of irrigation. And at the end, this is the picture. So I'm always keeping the spinous process. Maybe only the Ponti places here that removed, but always I'm keeping the Ponti. I'm putting a lot of synthetic bone graft, especially the syndromatic or the cerebral palsy cases, and mix it with vancomycin powder. So maybe there is argument with the vancomycin powder, but I'm super selective with the vancomycin powder. And this is a meta-analysis, and it's concluded that may not increase the rates of gram-negative or polymicrobial spinal infection, but can significantly reduce the infection rate of gram-positive bacteria. And this is the target in those cases, because if they pass the complication intraoperative with the bleeding and inshallah no mortality with them, you don't want to go in the infection problems post-operatively. So luckily this case was managed very well. Alhamdulillah, and this is the correction. So if this is the picture immediately post-operatively, if you can see the shoulder is a bit down here, so maybe I was aggressive with the correction, but I waited for 6 months, and this was the last X-ray for her. 6 months, and there was no complication. The lung was opened, and the patient was really super satisfied. And I remember in that last visit, she asked me if she may join the medical college. I told her, yeah, of course you can join the medical college, but don't join the spinal surgery, please. So this is the X-ray. She had bitter kyphosis, I may say, preoperatively. Maybe she's now a bit flat here in the kyphosis. Hopefully she will continue like this. And this is the case. So in conclusion, syndromatic case, you need to go for preoperative plan, a lot of preoperative plan, and don't ignore any other problems, especially the aortic dissection in the Marfan syndrome. Preoperative elasticity played a lot of, I was lucky with the elasticity she's having. All from posterior, although I agree with the traction, but I don't have the setup for traction, unfortunately. Minor details. So back to these puzzles here, a lot of details in scoliosis surgery, and many mentors, when I was trained, they told me to be successful in scoliosis or deformity surgery, you need to concentrate on the minor details and the fine details of the to achieve the great results, inshallah. I know many of you have a lot of questions. I love to have them in my Instagram, Scoliosis Saudi Arabia, and we can discuss a lot of opinions, a lot of X-rays, a lot of things. Thank you very much.
Thank you. We'll move to Dr. Bassi since we are running out of time. Thank you, Dr. Salah. Dr. Bassi, we all are yours now.
Thank you, Dr. Ahmed, and thank you for letting me share this amazing event. This is a very nice case. I had it before, and there is many lessons that we learn from similar cases. And the most important thing is just to see where I went through and just to do or not to do in future. So this is a 44 years old male. This guy, he's a very intelligent person. He came from Taif on a wheelchair. To me, he has a paraplegic from incident when he was young. He had brain surgery, and it seems to me he had ended with lower limb weakness and paralysis. He had spastic paralysis. This guy, although he had paralysis, but still there's some sensory still maintained lower limbs as well the bowel bladder function. He's a smart guy. He came several times to my clinic insisting that he wants to have corrective surgery because it seems to me that he had the developmental kind of scoliosis, which we call it the de novo scoliosis. He has no, it has been recorded with the time that he had the progressive deformity that affecting even his lung. So past medical history, as we mentioned, he had kyphoscoliosis. It could be polymyelitis or residual paraplegia from the previous surgery. He had type 2 respiratory failure, secondary to chest deformity. He had the restrictive pattern and he is on home oxygen. Previous history of DVT, he is on Xarelto. Hypertension, and sometimes the blood pressures keep jumping. It's sometimes uncontrolled. We did echo for him. His EF is 55 to 60%. He had also, there's a mass in the left lung, which is not affecting him. And he was ex-smoker. He quit 1 year ago. So he keep coming to my clinic for 9 months, complaining that the deformity is progressive. Now his respiration, the lung function and the lung capacity become even weaker. He's more and more demanding of the oxygen. He went to the pulmonologist and they did pulmonary function test and they sent him to me as surgical correction for his deformity. Can improve his lung function. I tell you what, when I looked at the guy and his X-ray, you can see here his X-ray. I wasn't so really happy to touch a difficult and challenging situation. It's not because of the deformity; it's because of his comorbidities, the lung function, and he had also chest infection several times. He was admitted about 6 to 7 times. When he came to me, his lung was clear, and this is what we have. If you look at the X-ray here, this is the mid-sagittal line. You can see the pelvic is tilted to the right side. Here the curve, the lumbar here, and it's about 80 degrees, similar at the thoracic level. The lateral bending view, you can see it's really stiff, curved. He's just using his pelvis for tilting, actually. If you look here as combining, when you look at the lateral view here, you can see there is a huge gibbous. So he has 3 deformities. The first one at the thoracic, the other one is at the lumbar level, and also he had kyphotic deformity. So after reviewing his CT scan, you can see the 3D CT scan. I just choose some of the cuts here, so it will be the deformity. You can see it more clear here. You can see how the deformity here, the 2 levels here from the sagittal, and you can see there is a bone fusion here. Look at the lamina here. The lamina here is fused with the facet. So this is really a stiff curvature at this level, but here it's flexible. So the thoracic level keep increasing the curvature. This affects even his setting. You see the way how the pelvis it looks like. So he had more pressure at this area and it started causing some pressure sore. So this guy, his life actually is really miserable. So you can see here the CT scan. We did the chest CT scan for him. We did the ECG echoes before we decide to proceed with any surgical planning. So Ahmed, what do you think?
It's a very challenging case. If I get this case, definitely I'm going to refer it to someone else. But yeah, the most things that strike me and scares me is that he has a lumbar kyphosis. And
yes.
That's the most challenging, I think.
So for the speakers, do you have any suggestions? What would you do in this situation? Do you have any thoughts and ideas?
It's a very stiff, of course, curve. So if you want to do something, it's going to be the big surgery. So it's a mainly lumbar kyphoscoliosis with probably compensatory thoracic curve to the other side. So it started in the lumbar area, and that's why I think it's kyphotic in the lumbar area. So most probably, if you want to do something, you will need to do a vertebral column resection at the apex of the deformity, like around maybe L3, L2 or L3, something like this, because it's the only way to make it flexible. It's rigid, the discs are fused, the laminas are fused. So if you want to do something, you will need to proceed with the most aggressive procedures, which is going also to be very difficult to correct with all the risks. But you said he's paraplegic or something like this, so maybe the risks are not very important if he's in the wheelchair.
Yes, that's what makes me even more to accept the challenge in this situation.
Yes.
And also, if you look here, look at the ribs here. That rib is hitting the pelvis and it's causing pain, actually.
Yeah.
And this is one of the major. Yes,
conflict.
and this is one of the major things that similar cases they come to your clinic. It's not just the deformity, the lung, and the pain at the costopelvic region. So, any other ideas?
Dr. Salah?
Well, I think it's really challenging, but if I may say, it's I will try my best to go from to minimize the number of surgeries for him, because probably he needs more than one stage or two stages. So maybe 2 PSO from the lumbar and another PSO in the thoracic, and we will see. But it is really difficult. It needs a lot of planning. VCR is good, but I don't know if he can manage to go for 1 VCR or more, which is too much for the patient. So a lot of bleeding and yeah.
I think the point here for this patient, since he's paralyzed, he is the main things is the sitting is the sitting for him. So surgery is indicated for this patient for seating. صح, Doctor? Is that the reason, Dr. Bassi? Because he's sitting.
Yeah, I wouldn't actually from the first visit. I wouldn't touch this patient because it's challenging, and as my colleagues they mentioned about the difficulties and need pre-planning. But as Ahmed you mentioned, yes, one of the problem is the sitting. You can see the pelvis here is tilted, and also the pain from the rib here. And the third reason because of the lung shortness of breath, and it's causing more restrictive lung disease. So there was
someone will argue why you're gonna operate on someone who's not moving or he's not a walker, but we do this a lot in pediatric neuromuscular cases, that we do the surgery only so we can let the child sit comfortably, and I think this is the situation here.
Yeah.
Okay.
Actually, yeah, this is because of these 3 reasons I start to look again on the study. If you look here, this curve here, the lumbar here, so we are dealing with 1 curve here, the upper thoracic here, we have 1 curve, and the third one here, it's the thoracolumbar area, it's concave. So I thought if I managed to do pedicle subtraction osteotomy, and I managed to do 3 actually, I did 1 here, and I did the wedge osteotomy to the side. So I played with the pedicle subtraction instead of taking the higher zone from the posterior to anterior. I take it from right to left. And then I did 3 actual pedicle subtraction osteotomy. 1 at the apical point here, the second one at the thoracic at T7, 8, and at the thoracolumbar T12, I did the 3rd one. So I managed to, as we mentioned before, that we are not, I think Salah, he mentioned that we are not targeting to bring a person imperfection. we are trying to solve his complaints, and his complaints is the pelvis, reduce the pressure on the lung, and push away the rib. So you don't have to look for perfection, just try to move it away, and the patient will accept any outcome. Try to reduce the time of the surgery, do it one stage if you can, and just run away. So this is what we have done. And if you look here, we managed to push. I have another X-ray, I'll show it to you later. But if you look at the pelvis here, it's becoming almost parallel with the ground here. So the pressure become more equalized at both sides. You can look here at the upper side, at the shoulder level here, it's almost level. The things that after we did the osteotomy, if you look here, the gibbous has been corrected. And if you look at this level here, here the challenge is that when I put the rod, that one, I used also screws at the iliac. When I put the rod here, you see this one from the right side, that rod, it moved while I'm going up. I moved to the left side, the screws, then I went back to the right side. When I put the rod this side, the left one, I put it at the pelvic and the L5, and then I jumped here, and then I connect back to the left side. Then I put the third rod here, and I put a connector to hold this curve to prevent it from getting worse. Believe me, with 3 pedicle subtraction osteotomy, this is the best you can have. But at least the patient, after the surgery, his lung function came back to improved, actually. Improved about 40%. His pelvis become more parallel with the ground. You can see here at this level. As well, the ribs came away. So, and he became even taller. So he was so happy, the patient. Unfortunately, these cases, it's really a challenging case. You can see here, it's becoming more corrective. And because of previous history of repeated infection, he developed infection at the lower end. And once you have infection, this is a nightmare. And I took him twice for debridement, but unfortunately, his lung could not stand for the major surgery. And because of his restrictive lung disease, he went with lung infection and didn't do well eventually. So my message here, if you take a case similar to this, you have to really be careful what you are going for. Is the lung really can compensate the correction, the age, if the patient is smoker or ex-smoker or not, the heart, the ejection also a percentage. Is it really? Is his heart can compensate also a major surgery? Think about doing one stage, but usually at the end, even with this kind of aggressive correction and improving the lung capacity, sometimes they don't do well. Thank you.
Thank you, Dr. Bassi. There's few questions, but more of comments. And one of the question, maybe we missed that. What was the cause of paralysis in this patient?
He had, there was a query because when I asked the patient about the past history, it could be a polio, one of the reasons, and the other reason he mentioned that he had a brain surgery. I think he had hydrocephaly, and they did what they call it, the cervical, the tubes drainage, and it was infected, and they removed it later after 11 months. Okay. So it was really, there is no documentation about what's the actual cause of his paralysis.
And his neuro did not change after surgery?
No, because this is, he's 44 years, so that we're talking about something happened 43 years.
Someone wants you to more elaborate on the third rod. Why did you use it?
Okay, the third rod here, you see there is, when we put the rod here, you can see there is a gap between that screw, which is about L2, and between the iliac, and this will cause more stress on the rod at this level here. So to share the pressure and the stress here, so I put conjoined rod here, the small one here, and I put a cross link, because even if you try, it's very hard to make a rod curved and going up. You will cause more stress, and you can end with the rod failure. So it's better in this situation, try to keep the rod straight as much as you can. Use adjacent rod, and by this way the stress will be shared between both of them.
Okay, we will conclude now. I would like to thank you all for this wonderful webinar, and I would like to congratulate you and myself on a successful webinar. We reached about 760 attendants. Thank you, Dr. Bassi from Dr. Salman Faqih Hospital in Jeddah. Thank you, Dr. Salahadden Khalifah from King Abdullah Medical City in Mecca. Thank you, Dr. Bachar from King Fahd Medical City in Dammam. Thank you, Dr. Anouar from Kingdom Hospital in Riyadh. Thank you, Dr. Samir from National Guard Hospital in Riyadh. Thank you, Dr. Alshoabi from King Fahd Medical City in Riyadh. And inshallah, we'll do more webinars, and there is one coming up in the next 10 days. It will be about cervical radiculopathy in a young age. It will be a multidisciplinary webinar. Inshallah, a link and link for registration will be sent out soon. Thank you, everybody. Assalamu alaikum.
Thank you.